Virendra.
Yeah, thank you. So a very good evening, everyone, and welcome to No Thrombosis program. I'm very glad to inform there are more than 1,000 delegates has been registered today, and because of your all the trust on No Thrombosis, because we have received the most engaging scientific platform award, from SEAMS Healthcare Excellence Award. So thank you so much for your the so interest in No Thrombosis program, and definitely we are very highly committed to provide more very meaningful and unique cases to in this platform. So No Thrombosis platform, it is the real platform where we discuss on all the real life challenging cases. And today our course director, we have actually I'm very glad to inform all of you that we have this event is our 12th program. So far almost 1 year or more than 1 year we are continuing this program, and almost this is the 12th program of our no thrombosis program, so specifically with Praveen sir and Vinayak sir. So Praveen sir is our course director, and it's very well-known faculty, in interventional cardiologist in India, and so sir has he is recognized as one of the leaders in angioplasty in country, and he is proficient in a lot of new devices and technology. He has been awarded for his contribution and services in the field of coronary angioplasty in India in 1998. Dr. Chandra sir has been a distinguished faculty member in various international meetings and was the organizer and director of the AMI course held in New Delhi 2005 and 2006. He has also published more than 100 articles and reviews and abstracts in various national and international scientific journals. Our second, our moderator is Dr. Vinayak Agarwal, sir. Sir is head of Department of Non-Invasive and Clinical Cardiology at Fortis Memorial Research Institute. Sir is having more than 20 years of experience. His responsibilities including being in charge of the heart valve clinic and the hepatic transplant cardiology division at the institute. Dr. Sir has spent a considerable amount of time on research, having conducted numerous clinical trials. So welcome to Vinayak, sir, for our program. And today's our moderators and moderator is Dr. Virendra sir. Dr. Virendra sir is Associate Director, Division of Peripheral Vascular and Endovascular in Medanta, the Medicity of Hospital, Gurugram. Sir has more than 16 years of experience in vascular and endovascular interventions. He is also a course director and founder member of Vascular Access Society of India. He is also reviewers of many indexed journals, IJRI, IJVS, and IJCIR. He's also published many articles in national and international journals, and he's also has been a principal investigator for many ongoing studies in India. He is a life member of many associations in India, and also he is the author of MCQ-based medical post-graduation entrance examination preparation book for MH Medical PG entrance. So welcome, sir. Welcome, Virendra sir, for our program, No Thrombosis program. And today's our speaker is Dr. Navjit Talukdar, sir. He's one of the greatest, one of the interventional cardiologists in Delhi, and sir has presently working as a senior consultant interventional cardiologist and electrophysiology and basing in Batra Hospital and Medical Research Center. He's published many articles in national and international journals, participated as a faculty of national and international conferences, webinars, symposium. Since Navjit sir has a lot of consistently, he is one of the participating in No Thrombosis program. I'm very glad that Dr. Navjit sir is today is in our program. Thank you, sir, and welcome to the program today. And today's our second speaker is Dr. Naveen Chowdar, sir. He is he's presently working as a senior consultant surgeon in PSRI Hospital, Delhi. He's expert in open heart vascular cases, endovascular, hybrid vascular procedures, vascular trauma, state of the art of diabetic foot care, participated in many national and international conferences as a faculty and won many awards in the field of experts. So welcome, Naveen sir. Welcome to the
Yeah.
No Thrombosis program. And today's our the agenda is that we are going with the first case with Dr. Naveen Chopdar sir, and second case will be Dr. Navjit Talodkar sir, and then the presentation will be given by Dr. Virendra Singh sir. He is giving a case specifically on new dimension in PAD, and then followed by we'll have a concluding remarks by course director and moderator. So with this, I will hand over to Dr. Vinayak sir for his the opening remarks. Thank you, sir, and welcome to the program. And over to Vinayak, sir.
Thank you, Ravi, for those kind remarks for all the faculty who are participating today. And I can only assure the viewers that the delegates who are attending that it will be a very lively and practical session. And we have very experienced faculty today with us. And I'm sure we're all going to learn a lot from each other and share our experience, which we have gathered over the last few years treating patients. So I would invite
Yes, Dr. Naveen, sir, I think we
Yeah.
have to start the session. I will
Yeah.
share the slide. Yeah. So,
Yeah.
slides are visible. I
So
hope.
I'm Dr. Naveen Chopdar. I'm a consultant at PSRI Hospital, Saket. So I'll be talking on complex and the recurrent DVT cases. So regarding the rivaroxaban, it is a direct factor 10 inhibitor. It was patented in 2007 and approved for use in 2011. It will not be available as a generic medication till 2014, and moreover, half-life of 9 to 13 hours can be taken with food. So rivaroxaban is approved in India, mainly used for the prevention of VT in adult patients undergoing elective hip or knee replacement as a prophylactic dose of 10 milligram, and again for prevention of treatment of DVT and prevention of recurrent DVT and pulmonary embolism 15 to or 20 milligram dose. Also used in stroke and systemic embolism in patient with non-valvular atrial fibrillation and prevention of thrombotic events in adult patient after acute coronary syndrome with elevated cardiac biomarkers. Also the same thing with the peripheral arterial disease at high risk of ischemic events. Rivaroxaban 2.5 milligram twice a day with the acetyl salicylic acid. Next slide, please. So as you all know, patient with DVT, they are at risk of PE. Usually the embolia travel through the heart and lodge in the artery of the lungs. So 90% of the patient of PE are the result of the DVT, and 82% of patient with acute PE, they have some detectable DVT at the time when the PE is diagnosed. This is the diagram which shows how the clot travels, and nearly 80% of the DVT are clinically silent. So patient at risk of VT recurrences are those with unprovoked VT, where no identifiable provoking factor is there. And in this sort of patient, indefinite treatment we continue. And provoked VT is the old age, moderate amount of renal impairment is there. And moreover, the risk factors are there in provoked DVT. And moreover, again, the provoked DVT example has been given is a frequent traveler and written 5 days ago complaint of pain and swelling in the leg. So provoked DVT, what we take into consideration is immobility, pregnancy, hormone therapy, age greater than 60. If it is sitting for a prolonged period of time, like during driving or flying, prolonged bed rest, and if it's a obese, weight normally twice the average body weight, smoking, cancer, inflammatory bowel disease, and genetics. Then risk of recurrences can at the end of 1 year, and moreover, same thing with the provoked VT and persistent risk factor, they have a high risk of recurrence. And with the transient risk factors like the patient with a minor trauma or on the OC pills, which can be reversed. So patient they have 1 in 14 risk of recurrence at 1 year. So regarding the Einstein trial, which have been mentioned, it is basically for the rivaroxaban in VT patients. So initially it was taken for the DVT and the PE. So it was a non-inferiority program. It was from March 2007 to 2011. It was, and treatment duration was of 3, 6, and 12 months. So primary outcome was the recurrent VT, and safety outcome was the major bleeding or the critical non-major bleeding. So then in the previous slide only. So it was again the Einstein choice. It was extended treatment. Einstein choice. It was compared with the aspirin 100 milligram, and moreover, it was a randomized double-blind study, phase 3 study. So again, in this study, it was found that rivaroxaban definitely reduced the VT recurrence without any significant risk in bleeding. Next slide. So again, regarding the efficacy, definitely it is definitely rivaroxaban is better with the 82% reduction in relative risk reduction and 5.8 in the absolute risk reduction. And it is definitely non-inferior to enoxaparin and the VK combination. And moreover, regarding the safety profile, it is definitely better with the enoxaparin vitamin K antagonist, and 99% of the patient did not experience any major bleeding with the rivaroxaban in the Einstein program. And who are the patients who should receive extended duration of treatment and who should? So this is the question. So this is the case one. Here is a 65-year-old lady, obese lady. So again, the risk factors are there by the Caprini score. If we go it, then the age is 65, obese, underwent surgery 1 week ago. So again, one of the risk factors. So received the thromboprophylaxis with low molecular weight heparin. Now the patient has pain and swelling left calf. Ultrasound shows thrombus in the popliteal vein. So what initial treatment would you choose for this patient? There are multiple options are there. NOACs, LMWH, VK, LMWH with the NOACs, or you admit to the hospital. So the patient received rivaroxaban 15 milligram twice a day for 21 days, followed by 20 milligram once a day. Now the question is, at the end of 3 months, would you consider treatment extension? So that all depends on what is the D-dimer level, and you do the repeat Doppler, any residual thrombus is there or not. And if these two are raised, if D-dimer is raised more than 500 nanogram per ml, or that it shows a residual thrombus, then definitely the treatment duration should be extended. It can be 6 months, 12 months. It has to be assessed at periodic interval. Assess the risk to benefit ratio. And moreover, if it is persistent, then the treatment can be indefinite. Again, the second case is a patient who is a frequent traveler. Again, he is 67-year-old. One of the risk factor, BMI is 41. Again, one more risk factor, he is a frequent traveler and returned 5 days ago. So swelling and pain in the right thigh, diagnosed with the femoral vein thrombosis. So we can continue rivaroxaban and advise him to reduce long distance flight and stop anticoagulants. Advise him to lose weight and stop anticoagulants, or stop anticoagulants, admit to hospital. So treatment plan after 20. So another case is 86-year-old lady, 58 kg, resident in nursing home, has hypertension, dyslipidemia, creatinine clearance is 45 ml per minute, extensive unprovoked DVT. Started with rivaroxaban. Rivaroxaban, no bridging is required. And after 21 days, considering we can continue with the rivaroxaban 20 milligram once a day. So at the end of 3 months, again, you have to assess the patient by Doppler for the VT recurrence. and for any residual thrombus, and assess the D dimer levels. If they are definitely there, then you have to extend the treatment. And definitely, since the lady is 86-year-old, definitely she has some amount of bleeding risk is definitely there in the old age. So dose and duration is initially for 21 days you give 15 milligram twice a day. Then from day 22 onwards 20 milligram to assess the individual risk. And after 6 months it can be prophylactic dose or therapeutic dose. If high risk of VT recurrence is there, then you have to continue the treatment. Thank you.
Yeah. Thank you, Dr. Naveen, for sharing that very interesting series of cases. So, I'd like to ask you one question, which is important. The last case that you showed, the patient was 80 plus, nearly 86, 58 kgs,
Yeah.
and we gave full dose of rivaroxaban. So, as
Mhm.
compared to other drugs like apixaban, where we usually bring down the dose to half,
Yeah.
any such considerations you think for rivaroxaban?
Sir, definitely in old age risk of bleeding is definitely there. So I agree with you. One should reduce the dose, and moreover, the creatine clearance was 45 ml per minute. So we can think of reducing the dose. Initially, we can give it for 21 days, and then we can definitely reduce the dose, not 20 milligram, or we can just give her a prophylactic dose of 10 milligram. Also, that should be sufficient.
Yeah. See, it's important that the patients who are in extreme body
Yeah.
weight, like for example, even if you take extreme body weights less than 60 kg or more than 120 kgs,
Yeah.
most of the data that trials have are not there for less than 60 or more
Yeah.
than 120 kgs.
Right.
Similarly, the age more than 80 is not very well represented in most
Yeah.
of the trials.
Yeah. Most of the trials.
But
Yeah.
so the only thing which I want to say is that in the elderly age group, I would say uh, rivaroxaban is safe. I'm not saying it is not, but if I have to choose in an 86-year-old, I would actually choose either apixaban 2.5 BD or
Yeah.
110 mg BD of dabigatran rather than rivaroxaban, only specific to that case in the elderly age group, right? Um Rivaroxaban is an excellent drug because it's once a day dosage. It is whenever you have a creatinine clearance which is less than say 30, you could decrease the dose to 15 mg OD, and that is good enough. It has very good profile, very good compliance. I have found excellent results in VT patients with rivaroxaban, patients who had significant pulmonary embolism. You give them 15 mg BD for 21 days and 20 mg or 15 mg OD depending on the background, and they do
Yeah.
exceedingly well. So it's an
Yeah. I agree
excellent
with
drug,
you.
but
I agree with you.
only in the elderly I have a slight reservation beyond the age of 80 years. I would.
Maybe
What do you
definitely,
think,
Dr. Vinayak, I
Dr.
agree
Viren?
with you because these are apixaban is definitely in that age group is better. 2.5 milligram twice a day, it's definitely better. Low risk of bleeding is definitely there
Yeah.
in that age group.
Though we can actually decrease in case we are not aware, we don't
Yeah.
have availability of the other drugs. One can easily go for rivaroxaban 15 mg. I
Yeah.
think that's quite acceptable, but
Yeah.
only in the elderly age group, I'm a little concerned about that. What do you think, Dr. Virendra? Any comments on that?
Yeah, sir, I agree. I mean, compared to the drugs which you have told, at least we have reversal for dabigatran 110 BD, and clearance wise in octogenarians. I mean, it's if they don't have other comorbidities, that's fine, but the risk is a little higher. I would say, yeah. I mean, we all are a little scared when we give
Yeah.
full dose. Yeah, but again, it depends on the creatine clearance. If she has a very good creatine clearance and no comorbidities, I think we can go ahead and use it as well.
I agree. I agree. So, one thing which I want to ask Dr. Naveen and other panelists is, when you get, do you risk stratify patients who come to you? Like in these cases, of course, we didn't have any problem because it was a provoked DVT. But suppose there was a patient who we did not have an obvious cause. So will you look for risk factors? Like, for example, the most common risk factors which lead to venous thromboembolism are cancer, antiphospholipid syndromes, patients who have been hospitalized with acute illnesses, of course, trauma and fracture and prolonged immobility. So prolonged immobility is defined as if you're bedridden for more than 3 days. And in fact, it's very interesting to know that whenever you have a surgery which lasts for more than 30 minutes, that is also a risk factor for DVTs, right? So do you actually recommend that, our delegates who are listening to us, what is your message to them in terms of, say, looking for provocable risk factors? What should they ask the patient specifically in terms of history to help them in deciding whether the patient has provoked or unprovoked DVT?
Yeah. So, sir, I mean, depending on the patient's age, as you told, if she's elderly or he's elderly, the first thing which strikes is to rule out malignancy. So we'll do the entire ultrasound scan. If he's a male, PSA, females, all the tests to rule out any underlying malignancy. That has to be done if it's an elderly. For a younger age, as I mean, we did like 2 days ago. So a female comes with an acute DVT. The first thing which we ask is whether she's on OC pills, whether she has started it, or she's taking steroid for some reason they have started. So these are very common reasons in a young female. So you have to see whether there is a provocative factor, because your treatment definitely depends on that. A lot of males who come without any history of trauma, no immobility, and then suddenly कि morning में मैं उठा and then I saw my swelling with no risk factors, then you know it's an unprovoked DVT. You may have to rule out the thrombophilia profile. So before starting anticoagulation, definitely you send those. So age is the criteria where you draw a line and then you advise the tests accordingly. So you have to stratify whether it's an provoked or an unprovoked DVT, because your long-term treatment will definitely depend on that. And then there is a entity called May-Thurner syndrome, which is again very common. So we do a catheter-directed thrombolysis, aspiration, ballooning, stenting, in a lot of patients who come with that. And then there is another entity which is NIVL, non-thrombotic iliac vein lesions, in which there are septations or a spur that leads to basically DVT. And there could be a provocation that leads to DVT. So patient may ask, "Ye 40 साल तक ठीक थी, अभी कैसे हो गया?" So there is a provocation. So in our institute, what we do is, if the creat is good, any patient who comes with a DVT, we do basically a CT. So we do a DVT protocol with CTPA. So in the same scan, you do the pulmonary as well as the entire IVC and the limbs, so that you can stratify, you can explain your patients in well manner. If there is a P or there is a free floating thrombus in the IVC, you may counsel them for basically an IVC filter if required, if you are going for a pharmacomechanical therapy. So a lot of things can be cleared, I think.
Yeah. So one thing, which most of the people keep saying, that you should use Wells score, etc. Do you use Wells score, or do you just take a, like a broad view of, say, whether, like just exactly what you mentioned in a practical sense? But do you think it would be prudent for the pharma companies who are dealing with these drugs to actually provide a Wells score chart for our, for all of us, to help us actually have a score, Wells score for DVT?
Sir, again, my take, others can answer. My take is that where you are working in a tertiary care center where you have an ultrasound right beside you and a CT scan that can happen in a couple of hours, we don't go with Wells care. But if I'm working in a center where I don't have an access, definitely all these scores will help to stratify. So it depends on where you are working. Yeah.
True. I completely agree, because see, most of these Wells score and all were developed for European and UK, etc., where a GP is
right
initially. That way, India is blessed that You have the facilities of highly trained, say, vascular surgeons, cardiologists, physicians, who can actually do the ultrasound within an hour or so, or CTPAs can be done with venograms very, very quickly. Within few hours, we can get them arranged in at least bigger centers. And even now, you can see India is so fast developing that even in tier 2, tier 3 cities, these basic things are available almost everywhere. So the scoring systems probably will take a back seat, but it's good to know that there are scoring systems which can help you have more risk attribution to the possibility of DVT. So I think before discussing any further, I will ask Dr. Talukdar also to share his case, and then we can have a discussion towards the end on both the cases. Thank you, Dr. Naveen. And I invite Dr. Talukdar to present his case.
Good evening. I'm in August company of Dr. Virinder. Hi, seeing you after a long time. And of course, Dr. Vinayak Agarwal. He had been a senior and a mentor since long. And Dr. Chandra sir is not here, but then, okay, I have abstention. So am I free to share my slide?
Yeah, please go ahead.
Yes, sir. Yes, sir.
One second, please. So are the slides visible?
Yes, sir. Yes, sir.
Fine. We straight away go ahead. So this will be a kind of a quasi, hypothetical plus current evidence-based judgment of the case of CAD with peripheral artery disease. Well, to see a case in of course, a real life scenario, 61 years old male patient with chest discomfort, class 2 symptoms and claudication for 1 year. He is diabetic, hypertensive, and had undergone PTCA to LAD 12 years back. Subsequent to that, he had undergone CABG with 2 grafts. And as early as 3 years back, he had to be PTCA'd again to the RCA. And he has diffuse atheromatous disease and bilateral lower limbs. ECG is unremarkable much. Echo, mild LV dysfunction with regional wall motion abnormalities of the inferior wall. Doppler study of both limbs, diffuse disease of anterotibial and posteriotibial vessels. Coronary angiogram, patent Lima, and SVG to PDA graft. And, he had a LAD and RCA total occlusion and LCX and mild CAD. So he was diagnosed as a CAD, triple vessel disease, and diffuse peripheral vascular disease, making him one of a very high risk patient. And he was given this current treatment, which is the flavor of the time, aspirin 75 milligram once daily, rivaroxaban twice 2.5 milligram vascular dose twice daily, or the compass dose, and rosuvastatin 20 milligram once daily, metoprolol once daily, ramipril 2.5 milligram once daily, ranolazine, and sitagliptin and metformin once daily. But why was it treated as such? Now, to understand this, we have to go a little bit 2-3 years back. This was in 2010 when Bhatt et al. Had published this data of REACH registry. It was 4-year outcomes of 64,977 patients who were more than 45 years old. A very close scenario. And they showed that risk of CV event and stroke at 4 years for risk factors only was around less than 10%. For so-called stable within inverted comma, atherosclerotic disease, it was around 12%. But those stable patients who are going to prior ischemic events, means already had some vascular events, either a TIA or a stroke or a ACS or an unstable angina, there the risks jumped to 17%. And surprisingly, if the prior ischemic events happen very recently, the risk is exponential. It jumps up to 21%. So there came the concept that perhaps the so-called stable coronary artery disease was not stable at all. Now, vascular protection has got therapeutic pillars like lifestyle, we all know, lipid lowering agents, we know, blood pressure reduction with very effective agents, and blood glucose control. Also, antithrombotic protection by aspirin and DAPT3. Now, DAPT means combination of either aspirin and clopidogrel or combination of ticagrelor in a lesser dose. For prasugrel, we don't have this kind of data, but this is what we were doing. Now, question is there any scope for improvement with current antithrombotic regimens? To understand this, let us have a little peek here. So we all know that in a coagulation pathway, the inhibitory drugs, the rivaroxaban, apixaban, this has been, and dabigatran. Dabigatran is a factor 2A inhibitor, and rivaroxaban, apixaban acts at the factor 10A. I am not bringing edoxaban out here because edoxaban is not available in India. So here comes the focus on rivaroxaban. Why rivaroxaban? I will come to that. Now, these data in antithrombotic treatment studies in patients with CAD was made in the background of the COMPASS trial. Now, they have shown the stable CAD patient on aspirin monotherapy with history of multivessel CAD or MI more than 1 year or less than 20 years back, if it is there. Additional risk factors are to be seen, whether it is diabetic, symptomatic PAD, CKD, heart failure, or prior lacunar stroke. Now, we have to, if all these are there, then we have to see whether the indication for oral anticoagulation, as for example, atrial fibrillation or high risk features for life-threatening bleeding, like anemia or history of bleed or bleeding diathesis or thrombocytopenia, liver disease, etc., are present or not. Point to be made is we have to also take care of extreme old age and frailty. This Dr. Vinayak Agarwal in his earlier talk also, and today also, he has indirectly mentioned that we have to be careful for these subgroup of patients for extreme age and frailty. If those are not there, then they had prescribed that we can give aspirin and rivaroxaban twice daily. Now, if the patient has already got an MI and treated with DAPT and coronary angiography mandates CABG, then again, we see the other additional risk factors and go ahead. If the patient has undergone a conservative strategy or a PCI, then we see whether there is multiple disease or extensive CAD is present there or not, and if there is intolerance to ticagrelor or not. Because ticagrelor was supposed to be one of the best agents for prevention of such events. Then we have to see history of ischemic stroke is there or not. If those are not there, then we go for prolonged DAPT with aspirin plus ticagrelor, means down titrate from 90 to 60 milligram twice daily from 1 year post-MI. Now, new guidelines recommended a second antithrombotic in selected patients with chronic coronary syndromes. In 2019 guidelines, it was, of course, the level of evidence was 2A and the class of evidence was 2A and the evidence level was A. Now, they had stratified, the concept has started coming to juggle between the high ischemic risk versus big stratified ischemic risk patient. Now, high ischemic risk was defined as diffuse multivessel CAD with at least one of the following factors, like recurrent MI or diabetes. Diabetes we know is almost an MI risk equivalent, or a PAD or a CKD with eGFR less than 60. Of course, less than 15 was not taken because these are ESRD patients. Now, moderate ischemic risk is at least one of the following: multivessel or diffuse CAD, diabetes requiring medication, recurrent MI, PAD, heart failure, and CKD, again this. Now, the concept of dual pathway inhibition was there. Now, dual pathway inhibition actually targets the persistent thrombin generation, because we have seen that there is nothing chronic in the chronic coronary, chronic stable angina patients. In fact, the chronic stable angina group has been renamed as chronic coronary syndrome. This means there is a recrudescent and smoldering process going on in the entire area, wherein three major subgroups are seen, where we have stuttering events, then we have events interspersed with treatment, and then some group was. stable. Now, in the acute phase, the main target is the prevention strategy of stent thrombosis, etc., etc. So DAPT is required. Even in post-surgery patients these days, DAPT is required minimum of 12 months. Now, why this is so? Because platelet activation is strongest in the acute. In the so-called chronic phase, as the time goes on, there has been seen that prolonged thrombin generation plays a big role. So if we target only the platelets, it might not be a prudent way. So we started targeting the prolonged thrombin generation. The background of it was on the background of all these trials till COMPASS came. Now, COMPASS showed decreased MACE to the power of 24%, decreased cardiovascular deaths by 22%, stroke by huge 42%, and MI by 14%. Of course, the reduction in MI was non-significant. And there was bleeding, and I'm coming to the further analysis of this with the number needed to treat and number needed to harm, etc. Now, COMPASS is the only antithrombotic regimen showing significant reduction in all-cause mortality. Now, what was the regimen in COMPASS? This was patients must meet criteria for CAD and PAD or both. Now, CAD patients, criteria for CAD was previous MI or at least within 20 years, multivessel coronary artery disease with symptoms of stable or unstable angina, or undergone PCI, multivessel PCI or CV. Now, single vessel PCI or simple Lima graft was not included. Patients with CAD must meet at least one of the following criteria: either age more than 65 years or age less than 65 years plus atherosclerosis in more than 2 vascular beds, or 2 additional risk factors like current smoking, diabetes mellitus, eGFR less than 60, and non-lacunar ischemic stroke more than 1 month earlier. Now, for PAD patient, previous revascularization, previous limb or foot amputation for arterial vascular disease, history of intermittent claudication in one of the following, defined by one of the following, ABPM of less than ankle arm BP ratio of less than 0.9, significant artery stenosis more than 50%, documented by angiography or Doppler ultrasound, previous carotid revascularization or asymptomatic coronary carotid artery stenosis of more than 50%, and CAD plus low ankle Beckett index of 0.9. Now, COMPASS trial targeted more than 27,000 patients. 2 groups were compared: aspirin 100 milligram twice daily only, then aspirin plus rivaroxaban 5 milligram twice daily, and rivaroxaban 2.5 milligram twice daily. COMPASS is the first NOAC and antiplatelet combination therapy trial to demonstrate significant reduction of MACE in stable atherosclerotic patients. Now, what is this found? In riva plus aspirin versus only aspirin, the MACE was reduced by 25%. Net benefit was found in 20%, decreased mortality in 18%. Now, the questions came in post-interim analysis where it was seen that whether only with riva the benefit was accrued or not. It was seen that only with rivaroxaban 5 milligram twice daily, there was no additional benefit. The primary outcome was 24% lower with rivaroxaban twice daily plus aspirin than with aspirin alone. These are the same data, the teased data. Now, clinical implications of COMPASS is an implication to switch from DAPT therapy to dual pathway inhibition. Means from DAPT to DPT therapy. And DPT therapy, because only one trial has been done, it is rivaroxaban plus aspirin. Therapeutic use and clinical benefits of dual pathway in both CAD and PAD pathway seen. And 2019 NICE guideline has said that rivaroxaban plus aspirin is recommended as an option for preventing atherothrombotic events in adults with CAD or symptomatic PAD who are at high risk of ischemic events. Well, now, one or two comments I want to make is why did we see the net clinical benefit? Because logically, if we use 2 agents, we are supposed to see 2 measure more increased bleeding. But this was not seen. In fact, the bleeding arm was high in only aspirin group. Why it was seen? Probably it was seen because there was overwhelming decrement in events, both in MACE and cardiovascular events, in favor of rivaroxaban plus aspirin dose. And when the net NNT or net number needed to treat for the benefit was found, it was less than 100, it was 91. And when we see the bleeding events, number needed to harm was 63. And the benefit was more accrued in those patients who were more than 65 years, who are having impaired renal function, who are having diabetes, and who are having heart failure. So this is a wonderful strategy as of available now. But yes, only one trial would not qualify for entirely changing our practice, and hence more teasing of the data is required. But however, in patients with polyvascular disease, diabetes, somewhat impaired renal function, those who are not very frail, I would like to add the term that less than 85 years and maybe 50, 60 or more, not less than that, not too much frail patients, and who are having polyvascular disease, there the addition of rivaroxaban with aspirin is perhaps the need of the hour. Questions remain is how long? Now, to understand how long, the COMPASS trial had been followed for 3 years. Till 3 years, the benefit accrued in the COMPASS trial went on extending. In fact, the magnitude of benefit was more in 1 year compared to the end of 2 years, and it continued to accrue till 3 years. Well, it might be too overwhelming to, trumpet this drug such way. In any case, it is the primary duty of all our physicians that we should be careful with the data and we should weigh, debate, understand, and follow. But yes, the current evidence, if we talk now, is this. So, my learned friends and Dr. Chandra sir, my regards. I am seeing you after a long time. So, we'll ask your comment. And of course, Dr. Vinayak Agarwal, I know he will give some fantastic comments. And of course, Virender Shevranji, please join in and share your thought.
So thank you, Dr. Talukdar. I think, this was a wonderful, presentation you did. And I'm sure most of us now agree that adding rivaroxaban in chronic CAD patients who are high risk, it is an absolutely reasonable strategy to bring down the events over the years. And of course, we don't know exactly for how long, but certainly for a long-term basis, this medicine has to be added. And most of my friends and all my colleagues here sitting will agree that, of course, we need to have more and more data. But at the moment, it is reasonably well established from the COMPASS and the REACH registry that we are absolutely safe to start this therapy in most of our patients who are having chronic CAD, which means beyond 1 year of any intervention or bypass surgery, or who are having very high risk features. So I think this is where I will end, and of course my colleague Dr. Vinayak and Virender will speak more about this. Thank you very much.
Good evening, sir. So, Dr. Navajit, I think you presented a very good overview of a complex issue. And most of your talk actually centers around 2017 publication of COMPASS trial. This COMPASS trial is actually a landmark trial, if you ask me, because of the fact that it highlighted the role of dual pathway inhibition. Dual pathway basically means addition of an antiplatelet, which is aspirin 75, and say an anticoagulant, which is in this case rivaroxaban. And it's not that this molecule or this combination was not tried earlier. Like if you look at the acute coronary syndrome, this combination was actually tried in Atlas ACS2 TIMI51 initially, and that is from where this dosage came, that should you use 2.5 BD or should you use 5 mg BD. Now here I want to tell you one thing which is important, that when you add rivaroxaban 2.5 BD to 75 mg of aspirin, what it does is it causes dual pathway inhibition. So one is the antiplatelet, the other is an anticoagulant. So it decreases the risk of major adverse cardiovascular events of MACE by 25% or so. But maximum benefit was seen in PAD, peripheral arterial disease, and I'm sure Dr. Virendra will also agree with me. And it also decreased mortality by 18%. So this was a very significant trial. But why is it that it's been 3 to 4 years before we have started talking about it? Nobody actually gave much credence to COMPASS trial in 2017-18 because it increased the risk of, this combination increased the risk of bleeding by 70%. But what happened was that most of these bleeds were minor bleeds. There was no increase in fatal bleeding. There was no increase in intracranial bleeding. Minor bleedings were, which increased, but the trial somehow got buried in this 70% issue, that it causes more bleeding, and hence nobody really gave credence to the fact that this was the only combination with decreased mortality by 18% or so. So it is not a small trial. I think it is important to understand that if I have to choose dual antiplatelet therapy versus a dual pathway inhibition, dual pathway inhibition is far better in terms of decreasing mortality, decreasing the MACE, decreasing PAD, decreasing many other things, many other adverse effects. Okay, it may increase the minor bleeding on the way, but it is not going to cause more death. It is actually going to decrease mortality. It is not going to increase your intracranial hemorrhage. So in a patient who is at risk of bleeding, you should be careful, but you should not shy away from using this combination of aspirin with rivaroxaban 2.5 BD, because it's a far better combination in patients who are more than 65 years of age. And what Dr. Talukdar just told you, the inclusion criteria. So all these patients, most of our patients like that, somebody who's had a myocardial infarction, angioplasty, bypass, multivessel angioplasties, or stentings, some patient who has peripheral artery disease, previous amputations in a diabetic, all these people who are above the age of 65 or have multiple risk factors with smoking, CKD, etc., heart failure, stroke. So these are the patients where if you give DAPT, it is not going to improve their outcomes in the long run. But when you give them dual pathway inhibition, they will benefit in the long run. So most of the high risk patients, you should use this combination without really fearing that it may cause extra bleeding. So this is what I would like to emphasize on.
Yeah, one point I want to make is, it took 300 years after Copernicus told that Earth was, the current shape. So it is no surprising that it took 3 years for us to understand the importance of it. In fact, the interesting thing is we started understanding the role of, more focus was on the coagulation pathway in the light of COVID. Because in the first part, when we started seeing explosive vascular events, if you remember 2.5 years back, the first strategy after all these 15, 16 drugs, whatever was given, was found that when the first autopsy study was done in Indian background in Bombay, they found that the whole lung was filled with thrombus. Then they putated mechanism of the interplay of AC inhibitor versus AC receptors and the supposedly triggering pathway of means this coagulation thing came. We also have, we actually forget, but around 12 years back, there was a very nice review in Enigen, Mechanism of Thrombosis, wherein they had teased out, I think Ekelbaum had done that, Ekelbaum group. They had teased out two pathways of propagation and formation of thrombus. One in the acute phase was based on the platelet nidus. Okay, there was an initial platelet nidus which was fanned by activated platelets and endothelium, and thus with the background of a ruptured plaque or something, this thing in the endothelium, they could cause thrombus. Still others, they found where the thrombus was not acutely forming, and hence it would manifest many days later. And there, in that group, it was found that the persistent thrombin generation is at play. Why this so? Because in all the patients with thrombin is a patent vasoconstrictor. So whenever there is a increased thrombin generation, you see more spasms in the vessels, and thus maybe the benefits are more found. So now, if we go back to that research paper and see the current COVID understanding of the COVID, we now tend to understand how and why we see it better. Now, with the bleeding episode, actually, it was found, interestingly, that in only aspirin subgroup, the bleeding was surprisingly bigger. Although it was in more than 65 years of age, the life-threatening bleed was bigger in only aspirin group. Now, the other small bleeding are actually termed as nonsense bleeding, like ecchymosis, petechiae and all. So that actually doesn't translate into reality. Like clopidogrel unresponsiveness, 60%, 70%, but it doesn't translate into reality. We all know, and Dr. Vinayak will agree that these data in vitro and in vivo is many different. Yes, we have to understand it better. Even I am, despite being a strong votary, I also have many doubts, because until and unless another trial of such magnitude comes, we have to use it. But yes, as Dr. Vinayak has told us, that we have to carefully select the patient. We should only restrict now in the exact subgroup of COMPASS trial patients. Means there has to be a polyvascular disease, there has to be a coronary event, impaired renal function is there, and yes, frailty and advanced age group is definitely out. Okay, so I think that's all I wanted to say.
So see, I agree with Dr. Talukdar that I want to reiterate the fact that please understand that whenever you use either dual platelet or dual inhibition pathway inhibition, the risk of major bleeding will increase. So it is not that they can have GI bleed, they can have hematuria, they can have significant bleeding. Now, if suppose somebody gives you a history of peptic ulcer disease in the past, or has had significant bleeding in the past, has an active piles, or has had a recent hematuria, etc., I will not give them dual pathway inhibition. I'll probably give only aspirin at max. Now, suppose there is somebody who you know is reasonably okay, has not had any history. So you need to take careful history in these people, because they did increase this, any group, whether it is dual antiplatelet, DAPT or DPI, both will increase the risk of bleeding. So you have to be careful, take the history, and then go ahead and use this thing. The other thing which I want to ask is that is that the bleeding criteria differ. For example, here in these COMPASS trial, the ISTH criteria, the International Society on Thrombosis and Hemostasis criteria, were used, which is very different. It is more relaxed as compared to say the other more stringent criteria,
TIMI bleeding score and
TIMI bleeding score, etc. So here, obviously, it inflated the bleeding risk to 50%, 70%, but they may not. Most of them would not have been. Like a nosebleed will, maybe if they reach the hospital with a nosebleed, it will be considered a major bleeding. So like that, there were a lot of say reasons. So I think what I'm trying to say is that dual pathway inhibition is superior to DAPT, number one. dual pathway inhibition should be used more and more in patients who are at higher risk, multiple comorbidities, somebody who's getting recurrent MI, recurrent. So stroke is not included in this, because if you look at COMPASS trial, patients who had hemorrhagic CVA or had a stroke within the last 1 year were excluded from the trial. But if you take a subset of COMPASS trial in about 1,000 patients who were there in COMPASS trial, they showed that it decreased the risk of lacunar infarcts and ischemic infarcts significantly. So it is a
42%. 42%.
Yeah, but stroke was not really one of the reasons for DPI, though it is conceptually a good concept to use DPI in them, but we're still awaiting trials. But when it comes to CAD and PAD, so MACE and MALE, both were significantly decreased by DPI, and you should definitely use it more and more in this subgroup. I like to actually take Dr. Viren's opinion, because he's a leading vascular surgeon and he sees a lot of amputations, vascular disease. What is your take, Dr. Viren?
Yeah, sir. I mean, we agree. We are not in a situation where we can tell our data. I mean, we haven't seen any major bleed since we have started this DPI. The initial worry was like post stenting or post bypass, where we used to give dual antiplatelets, and we were used to that. So we were really skeptical that with ecosprin and that 2.5 rivaroxaban, whether it will be sufficient for the stent to be patent. So because I don't know, from the coronary perspective, you guys still go with Brilinta or ecosprin. So there was a trial which came out after COMPASS, which is basically a Voyager PAD.
Voyager PAD, yeah.
So in Voyager PAD, they said like with after any revascularization, the patient should be kept on ecosprin 100. I mean, we don't have 100, but we give 150, and then Riva 2.5 BD. So initially we were, I mean, we had no confidence that the stent may go away, whether it may thrombose, but now slowly after plasties, Belloni angioplasty, we started with patients, diabetic patients, non-healing bone, Belloni angioplasty with no stents. So we have started using ecosprin and Riva, and definitely the results are better because of the DPI pathway. With stents also now, I mean, what we are doing as of now, we keep for dual antiplatelet for a month, and then we stop clopidogrel, and we keep them on again this DPI. So still haven't gone that close post stenting, but any patients in which revascularization is not done, or we start early, same pathway. So we have definitely shifted. It's a big trial, I would say. So our prescriptions, our treatment has changed in this couple of years, I would say. We never used to write such treatment, and haven't seen any adverse event. I think Dr. Naveen will agree.
Dr. Naveen, what is your view on, you see a lot of, Dr. Naveen has been my colleague earlier, and he does a lot of peripheral interventional work. So, Dr. Naveen, what is your experience with these patients?
Dr. Naveen, you have to unmute. Yeah.
Yeah. Now you can hear.
Yeah.
So in the OPD, like those patients with the non-healing ulcer, suppose if they have this good Doppler signals and all that, we definitely give it aspirin, this rivaroxaban 2.5 milligram BD, and definitely the healing is better in these patients as compared to the single antiplatelet what we give. And moreover, as Dr. Virendra has already said, like post stenting and post angioplasties. So post stenting, what we initially we were a little bit conservative regarding starting on rivaroxaban or apixaban, because anyone is totally apprehensive about starting the new drug. So initially, slowly we started. So the results were okay. So claudication, rest pain, and all that, they definitely improved with this thing. So that is what the take is. Dual pathway inhibition is definitely going to work.
So, Dr. Virendra, I want to ask you something, that when you do a peripheral vascular intervention and you put a stent, for example, so do you use single or a DAPT?
No, always DAPT. And I mean, it's very surprising, sir. It's all embryology, I would say. I mean, I do a carotid stent. I never use DAPT like clopidogrel and ecosprin. I always go with Brilinta. ticagrelor, because I have seen carotid getting thrombosed because of the high clopidogrel resistance. So it's embryology. In lower limb in last 10 years, I hardly remember a case. I mean, even if we have not started dual antiplatelet, just patient is on ecosprin, because sometimes you have to convert to hybrid and open. So we keep on ecosprin and low molecular weight heparin. And we can just, once we have stented, we load it with. Haven't seen any stent getting thrombosed in SFA or iliacs.
No, I'm asking you this for a reason, because you mentioned the trial of
Right.
Voyager PAD.
Right.
So Voyager PAD actually compared aspirin with aspirin plus rivaroxaban
Right.
by BD.
Right.
So that shows that the general use post revascularization is just aspirin.
No, sir. They did 3 arms actually.
3 arms, okay.
So when they excluded the clopidogrel arm because of increased bleeding, but the general consensus, if I mean anywhere in the globe, I would say most are with the dual antiplatelet. I haven't seen anybody with only ecosprin. No. No. I think they compared it. I don't know, because of the high risk, but there was no added advantage. Dual antiplatelet with.
In Voyager PAD, they obviously, we know that triple therapy will always have very high bleeding. But in Voyager PAD, the fact that they gave only aspirin means it must be, you cannot give aspirin alone unless there is enough indication that it is viable treatment option for PAD, post revascularization. So I want to ask is DAPT a choice or compulsion? Like, for example, in our coronary interventions, DAPT is a must for the first few months. But is that a must in PAD or not?
Sir, I think we follow you guys, to be very honest. Most of the data comes from coronary.
Yeah.
So, yeah, Dr. Taluk.
Yeah. Now, a little bit clarification. So, in terms of carotid, data is very clear. Carotid endarterectomy is the best treatment, right? It is the best treatment now. Now, I also do a lot of carotids. Just karna padega, and patient aa gaya to karenge.
Best treatment bol sakte aap Talukdar usko, it is almost equivalent.
Yeah, I mean, there are indications for that surgery can't be done.
Sir, we are just becoming frank.
Yeah.
I mean,
let us call a spade a spade. So now, if you want to do a carotid stenting, yes, Dr. Virender is very correct. These days, I have also started using ticagrelor 90 milligram twice daily.
Right.
But the data there are small data. Large volume data is not there. The large volume data is actually aspirin and clopidogrel. But thing is, now further, Dr. Virender has pointed out a very common thing, that a lot of stent thrombosis does happen. But when we see the mechanism of stent thrombosis in those, mostly are procedure related. What happens in carotid stenting is carotid stenting has got a steeper curve, So in initial part, many of the operators, they don't oppose the stent quite well. And one of the main factors for is the stent selection. In selected cases, we have to see whether we have to go for a self-expanding stent versus a balloon expanding stent. These are dependent on the lesion characteristics and also the procedural characteristics. So most of the thing is actually procedure related. But yes, Dr. Virender's point is valid. Now there are increasing volume of data, and maybe in 1 or 2 years, we'll be started using the newer antiplatelets. Regarding the peripheral arterial disease, their data is very clear. If we use a stent, DAPT is required. If we don't use a stent, the peripheral vessels heal in 4 weeks. So 1 month of DAPT is good enough for the bridge period. After that, the vessel is maintained. And sir, Dr. Virender sir has mentioned a very nice word, that is embryology. Fantastic. Because in the coronary, you have vascular beds from ectoderm and mesoderm meeting. That is why in the LAD, proximal LAD, we have the maximum restenosis.
So I will try to clarify the question which I asked Virendra for. See, if you read the Voyager PAD trial, so in the discussion also they discuss that as you just said, exactly, that most of the data, if you look at the class 1 indication for a patient who has a PAD, the recommendation is only monotherapy with either aspirin or clopidogrel. This is what is recommended. When you add 2 DAPT in a patient who is not had undergone vascularization, revascularization, only peripheral artery disease significant, DAPT is 2B. Now, most of the extra data after revascularization, when you put a stent or a surgery, is derived from coronary trials, where you've seen that, okay, if I put a stent, DAPT is better than monotherapy. So you have extrapolated it to a peripheral artery disease where the stents are actually much larger. Coronary is 2-3 millimeter, maximum 3.5, 4. You have much larger arteries in the lower limbs. So the point is, so this is an extrapolation of the data from coronaries, and that is why in Voyager PAD, they have compared what is the standard treatment of monotherapy with aspirin with rivaroxaban 2.5 BD, which they have again extrapolated from the COMPASS trial and have they tried to see whether it matches or not. And this also came about because if you look at the Vorexpar studies, they showed that you can actually change the outcomes of these patients if you were to use anything other than aspirin as monotherapy or clopidogrel as monotherapy. So I think that is how it has evolved, and I feel that PAD is a area which is very wide open. I think we will see a lot of more recommendations as the trials happen, and I look forward to actually listening from you in future as to how we can change the therapy.
Achha, I want to ask one thing. What is the current status of silostazole? Because I remember, even I used to be very enthusiastic about silostazole in selected peripheral arterial cases where conservative therapy was being carried. So, Dr. Virender, what is your opinion?
So, I mean, I use in basically young patients, smokers who are typically that TA or Burgess, what we call. So where there is nothing reconstructable, there are big collaterals already developed. In those patients, I do use. And the other indication which I personally use is patients coming with mesenteric ischemia. So it helps in mesenteric ischemia. Lot of collaterals, SMA is gone, or maybe it's really stenotic, because stents don't do good in SMA. Self-expanding balloon-mounted stents, 1 year.
Is very high.
Very high. Self-extends 2 years. Now they have come with this newer drug-eluting stents, which may last for 3 years. Covered stent 2 years. So SMA stents patency is not good. So I try most of these patients on really high dose statins, DAPT. I mean, now we may start DPI, we don't know. But I start silostazole in such patients. And the mesenteric ischemia do improve. I mean, so there are very limited indications in elderly, diabetes, calcified vessels.
I have stopped putting stents in mesenteric ischemia. I only do thrombosuction. I only do thrombosuction, good thrombosuction, and a dilatation, and just leave it. What I have seen is you put a stent, and in many cases it closes off. You have bad events after that.
Yeah, it does. Yeah, Dr.
So what I want to say is that do you give silostazole along with aspirin in these cases?
Yeah, we do. We do give. Yeah, yes, sir. Yes.
So see, if you look at the data, it is very clear that for PAD alone, aspirin is silostazole has the same application as aspirin. I mean, monotherapy is the same as dual antiplatelet therapy. There is no recommendation to use silostazole at all over aspirin. It is the same effect. It is just that silostazole was proposed as a vasodilator as well, along with antiplatelet function. So you could use it. I think I will use it only if you have aspirin allergy or something.
Okay.
And if the bleeding risk is low and you think that aspirin is not very effective, then you could use it as a second antiplatelet other than clopidogrel. You could add silostazole to aspirin, but that's your clinical judgment. Maybe a 2B indication, but not really a 1 or 2A.
Yeah, it is not 1.
Yeah.
So I think it's quite late. We should.
Yeah, I think Ravi. I think we can close the. We've had very interesting session, good discussion from all our faculty members, and over to you now.
Yeah, thank you, sir. Thank you so much. And I really appreciate and for all our efforts by taken by our speakers, specifically Dr. Navjit Talukdar and Dr. Naveen Chopdar, sir. Very insightful. Today I think discussion has also happened. Specifically, I'm really thankful to Vinayak Agarwal, sir, and Virendra, sir, and also Dr. Praveen Chandra, sir. So, and very from behalf of Emcure, I'm very thankful to all our delegates, those who are today's presented. For those who delegates are present today or in our workshop. Thank you so much to all the delegates. And before closing this workshop, I would like to show one video, sir. It's our brand video, and then we will close this session.
Do you know which Indian pharma company has consistently launched innovative first in India products? Presenting Emcure Pharmaceuticals. With over 500 scientists, we are pioneers in chirality. We have been making a healthy difference to countless families. With cardiology at our heart, we have strived to give you better products always. Chiral products are complex to develop. They are difficult to manufacture, but their benefits make a difference. A difference for your patients, for you. We are proud to launch our latest chiral development, Exafib, our indigenously developed rivaroxaban. Developed in-house, manufactured at our state-of-the-art facility at Jammu. This is a WHO GMP certified facility. We conduct quality checks to ensure only the best is delivered. Exafib complements our chiral cardio portfolio. Exafib, committed to make a difference in anticoagulation therapy for your patients.
Very glad to inform everyone is that Exafib is from 1 year it is consistently number one brand in Indian rivaroxaban generic brand, and it is very evidently equivalent to the innovator in terms of the background study and mesogastric study. So thank you so much to all the prescribers and request all of you to continue to prescribe Exafib. And once again, thank you so much to all our faculty members, Dr. Praveen Chandra sir and Vinayak Agarwal sir, Virendra sir, Navjit Talukdar sir, and Naveen sir. Thank you so much and good night, sir.
Thank you. Good night. Good night.
Good.